Welcome. Good morning, everyone. Bienvenue. Mon nom est
Welcome. I'm Jean Lebel. I'm the president of the International Development Research Center, the IDRC.
Development Research Center here in Ottawa. Welcome to all of you in the room, as well as all of you that will follow us on our YouTube channel. As I mentioned earlier, interpretation services are available if you need it. The talk will be in English. In the question period, if you want to ask your question in French or English, they will be simultaneously translated by our expert in the box over there. C'est un grand plaisir pour moi.
Well, it's a great pleasure for me to welcome you here this morning, and also to welcome Dr. Cesar Victora,
University Federal of Pelotas in Brazil, but also the 2017 John Dirks Award in Global Health of the Gairdner Foundation. And we have with us today the Vice President of the Foundation, Summer Whitlock, that will also participate shortly into a short introduction. Those of you that are not familiar with this prize, the John Dirks Award on Global Health and the prize of the Gairdner Foundation, they are the most prestigious prize that researchers are getting in the world in domain associated with health, biomedical, medical research, and for the last few years also global health, and that's the one that Cesar received this year. You will have opportunity to hear from Cesar shortly. We'll give a talk on how we think locally and act globally, and how research carried out in Brazil have shaped global policy, has helped to shape global policy. And following the talk, Shaitali, our colleague from the Maternal and Child Health Program, will be having a conversation with Cesar in the seats over here, and we will have also the opportunity to take questions from the audience with the hope to wrap this up by 10 to 12. So if you have other commitment, this is where we are planning to finish. IDRC, as you know, is a crown corporation of the Canadian government. We provide support to researchers and institutions around the world in order for them to find solutions through the research process to the problem that they are foreseeing as being important, critical for developing their own country. And this is something that we have done for many years. In fact, our guest today was telling me, and has told us last fall at the official gala for the reception of the awards, that in 1982, there was a group of program officers that found him out in Pelotas. There was an ad put in a science journal about IDRC providing support. Him and his colleague wrote a letter to IDRC, and IDRC says, yeah, we're going to come and see you. Now, for those of you that are not familiar with Brazil, Pelotas is in the south part of the country. It's about a 4-hour bus drive still today to get to Porto Alegre, which is the next big city, where if you want to go out of the country, you need to take a domestic flight to Sao Paulo or to Rio. And then from there, you can travel, to Canada. So when Cesar get out of his home in the morning to take an international flight, he need to take about 10 to 12 hours of traveling time within Brazil before he gets on his first international flight. So, that's quite incredible. But it was quite incredible also in 1982 that we went there. Carl Smith, the program officer of IDRC, met with him. And they were in the early days of thinking that, breastfeeding, something that was low cost, ubiquitous, available, could make a difference in the life and livelihood of a population by having children, not only striving, but thriving in time. And the concept of 1,000 days from gestation to the first 2 years that are critical, as we all know now, has been built around the fundamental work of Cesar Victora with others in the world. But from this cohort of 6,000 babies in 1982 that is still followed today, you know, we have clear evidence coming from a country like Brazil that show the way that it's not only important to have the intervention taking place in the perinatal period, but to measure the impact across the life, and that's what Cesar will talk today. IDRC is quite proud to have been there, but as we always say, IDRC helped to build the platform. The researcher we are supporting are delivering the keynotes. So today, Cesar will deliver the keynotes, but before, let me please invite Madame Summer Wedlock, who is the Vice President and Director of Communication of the Gairdner Foundation, just to tell us a few words. Summer, please.
Good morning. It's my pleasure to be here on behalf of the Gairdner Foundation. I thought I'd tell you a little bit about our history and our mission for those who aren't familiar with us. So next year, we're entering our 60th year of presenting awards. We were founded by James Gairdner. James was a well-known stockbroker in Toronto turned philanthropist, and it was his vision and foresight that developed the Gairdner Foundation that we have today. So we have three main missions. The first is to celebrate and recognize excellence, and we do this through our Canada Gairdner Awards. Each year, we present 7 awards. They're in biomedical and also global health research. Our second mission is to convene leaders, and we do that through events like this, partnerships like we have with IDRC. We also host public lectures, symposium, and we're always bringing in leaders from scientific and academic communities. And our third mission is to inspire the next generation. So in the fall, we bring all of our laureates to Canada, and we run outreach programs from coast to coast. We're now working with about 23 universities. So Cesar came last year and spoke with many students. We bring in high school students, and they hear from our laureates about what inspired them to pursue a career in research in hopes that they'll be sparked to also pursue a career in that field. I often say that I have one of the best jobs in the world. My role is really to share fantastic stories of our laureates and the incredible groundbreaking work that they're doing. I had the great pleasure of getting to know Cesar over the last year and a half, even going to Brazil and going to his home country, which was fantastic. Dr. Victora was our first Brazilian laureate, so it was really great to give him that profile in his home country and also in Canada, and he still keeps coming back and taking that 24 hours of flight. So we're thrilled to have you back, Dr. Victora, and please join me in welcoming Dr. Victora to the stage.
Thank you very much. Good morning. I've already recovered from the long trip. The good thing is there's hardly any jet lag. It's only 1 hour difference, so it's just straight north to south. So in the next 30 minutes, I want to give you a brief recollection of what I have done over the past years, and I put in a provocative title, which is Think Globally, Act Locally. Yeah, well, that's we all know this motto. It came out of René Dubois from Rockefeller University, and I'm showing you where Pelotas is, which is way down in the south of Brazil, almost at the border with Uruguay. And so it's a pretty remote place to get to, as Jean has said. It's a historic city. He had lots of neoclassic buildings in the downtown area. It used to be a very rich city in the 1800s with the cattle raising and with the manufacture of dried salt milk or meat or jerky. It has a beach, a lagoon beach, but it's also, as any Brazilian city, it has very different neighborhoods. You know, Brazil is a very polarized country in terms of income distribution. We were, unfortunately, #1 in the world for many years in terms of the most highest Gini coefficient for income distribution. We're now, I think, number 12. So it's been getting better. We're not sure about the future of Brazil, as you may have read in the news. what struck me as I trained in medicine in the 70s was that I saw a lot of malnutrition and I saw a lot of diarrhea. And the same kids kept coming back to me all the time with the same diseases. You know, I would cure one episode and as a doctor, and then the child would come back in a month or two again. And I said, we've got to do something about prevention. And it struck me that at that stage, the average duration of breastfeeding in Brazil, of any breastfeeding, was only 2.5 months. Very, very short. Because, breastfeeding was antiquated and giving formula was modern. And Brazilian society was sort of in the process of becoming a quote-unquote modern society. And I said, well, maybe I should study that. And that motivated me to do my first studies. And I'm going to cover now 4 topics in this talk. And I'll start with exclusive breastfeeding. We got a grant from IDRC. And that was my first, and we decided to look at, does breastfeeding really protect against mortality? And there were actually no studies on that at that stage. There were some very old studies from US and UK when infant mortality was still very high in the early 1900s, but those studies had a completely antiquated methodology. And we say, let's use a state-of-the-art methodology as in the 1970s and 80s, which was a case control study. I wrote to IDRC. I got the funding. I think that was $50,000. That was a fortune, at that stage. And we did the study, which basically the main conclusion was that these are relative risks, okay? So compared to a risk of 1 in a child who was only receiving breast milk, the chance of dying from diarrhea in a child who received either formula or cow's milk was 14 times higher. No, that's a huge difference. If the child was getting some breast and some formula, it was 3.6 times higher. So this was impressive, but it wasn't absolutely new stuff. It was confirming something that we already thought happened. We knew it protected against morbidity, against episodes. We didn't really know how much it protected against mortality. But what was new was that following up with the same grant, we got on to study this little baby bottle here. In Brazil, we call that a chuquinha. Chuquinha is something that every baby used to get from the first week of life with teas or water, sugared water or herbal teas. And my kids got it. My kids were born in the 70s and 80s. So everybody gave them to them. And I said, let's look at this. And nobody had done that before. And then I said, okay, if you get 1 chuquinha a day every day, your risk of diarrhea death increases 42%. If you get 2 a day, it increases 100%. If you get 3 a day, it increases 186%. That was amazing because these are contaminated. These are poor families. The kids who die live in slums. They don't have treated water. They don't have even enough water to wash, and these things are really hard to wash because bacteria love them and they stay in the little between the nipple and the bottle. It's really hard to clean them. So that study was soon reinforced by finding from another study in Peru and another in Philippines. So ours was the first, but then the studies in Peru and Philippines were not about mortality. They were about incidence at a number of episodes. And also there was evidence coming out that breastfed babies don't need any extra water. The water that is in the breast milk per se is already sufficient. So they don't need to quench the thirst of breastfed babies using other types of water. And that led to a major policy impact. It was in 1991, UNICEF and WHO recommended exclusive breastfeeding for the first 6 months of life, which is a recommendation that's still standing today. Many countries have adopted it. Canada has adopted. Pediatric societies in most countries of the world are now recommending nothing but breast milk for the first 6 months of life. There's raises a whole number of issues about maternity leave and how to support that, but that is the medical recommendation. So some countries have made major progress in that. Now, the second thing that I want to show to you is that we then started worried about the growth of breastfed babies, because if you look at those lines, this graph in the right, the straight line at 0 is what a child should be, the ideal weight for a child at any age, okay? It's like a growth curve. The growth curves go like this, right? The weight is increasing. We flattened the growth curve. So a child who would be growing perfectly according to the norm that were available in the 70s and recommended by WHO, if you plot the growth of children who are breastfed, you get those lines, the dark lines. It looked like they are faltering. It looked that they are above the average in the initial months of life. And around 4 to 5 months and 6, they start faltering. And what happened? Well, the doctors and the nurses and the nutritionists would recommend formula. Say, no, this child is not getting enough weight gain on breast milk alone. So let's introduce something else. Now, it came to us that maybe the standard was wrong. Maybe the standard was obese. And if the standard was based, because the standard was based on a single study from Ohio in the U.S. of infants, all white infants, who were, 80% of them were formula fed. So it's basically a formula-fed standard. And this is when we decided that we needed to create a new standard. And now jointly with WHO, because of that early, before the initial push that we got from IDRC, that started 2 of our major studies, we started to get invited to all these new things, and I became an expert. We said, let's do this study. So I actually designed the study jointly with colleagues from WHO. We took mothers and children from 6 countries who were willing to breastfeed and who had no limitations to growth. I mean, we took high socioeconomic infants, so different ethnic groups. They had good health care, their mothers were well-nourished, they were non-smokers, the kids were not preterm, and so on. So we took sort of an optimal group of infants, and the mothers were willing to breastfeed. And we did this multi-center study, 6 countries, including Norway, Pelotas, Ghana, Middle East, Muscat, Delhi, India. And we kind of hoped that, but to our great satisfaction, these kids grew very, very similarly. As long as they were high socioeconomic status and breastfed, their growth was very similar in all these countries. You always think, Norwegians are going to be much taller than Brazilians. Actually, at 2 years of age, the Brazilian kids were 2 centimeters taller than the Norwegians. It's not a significant difference, it's a tiny difference. But if you select the kids on the basis of ideal conditions, they grow very similar throughout the world. And this is a study. We had a pilot study in Pelotas. All these pictures are in Pelotas. The people from the other countries came to Pelotas to be trained. And this is the first child who finished the study, Luisa, at 2 years in 1999. And the WHO growth standard were created, and now they're adopted in over 140 countries. So it's a real satisfaction. And for me, my grandson lives in New York. My son is an immunologist. And when he goes to his pediatrician office in New York, they use the curve I helped build. And there's nothing better than that. It can't get any better for a researcher. So really, really happy about that. Now, the third topic I want to talk to you about is the first 1,000 days. Jean has already briefly mentioned this. And the 1,000 days, it started conception, go up to the age of 2 years, and this is exactly 1,000 days. And this is the story of the Pelotas cohorts. In 1982, we had started the first study. Fernando Barros, my colleague, applied to IDRC for a grant. I was his co-investigator. And Carl Taylor from IDRC came all the way down to Pelotas, and we asked for $25,000. We thought, oh man, he's not going to give us that money. And they said, oh, you need 40. Here's 40, you know. So it was the only time in my life in which I actually got a grant was more than I asked for. And we really, we keep going on. We had a new cohort every 11 years. And if you look at the numbers on the right, 68% of those born in 82 are still being followed up. So it's a remarkable follow-up rate. People tend to stay in Pelotas. They don't migrate very much, which we're lucky about that. It's just pure luck. But we do have one of the longest cohorts. We started with 6,000 children. We now have 4,000 adults we're still following up. And then every 11 years we have a new cohort with high follow-up rates too. This hairy guy on the upper left is me. This is the first microcomputer in Pelotas, courtesy of IDRC. We got it with our grant money. There were no microcomputers at that stage, floppy disks, of course. We did everything on paper, paper questionnaires. This is our headquarters in the middle, interviewers phoning families to find out where they were. This is me on the right measuring. We also had to do some work, we didn't have that much money, so we actually got to do some work. Very different social conditions in Pelotas. So I selected 3 families here, one poor, one middle class, and one upper class. So analysis of inequalities has always been one of the landmarks of our cohorts. And this is what we are now. We have a state-of-the-art lab. We have genome-wide assays for the cohort members. We're doing a lot on body composition, and the people keep coming back. Obviously, when I started, I was worried about undernutrition, about diarrhea, about measles, about pneumonia, low birth weight. And now it's changed. So Latin America got heavy. Obesity is a leading problem. And look at that in our 4 cohorts. One of the great things about having 4 cohorts is that you can not only assess one cohort through time, but you can compare different cohorts growing in different time periods. Maternal overweight at the beginning of pregnancy went up from 22 to 47% now. And at 1 year of age, we had 6.5 kids with overweight, 6.5%. It's now 12.2. So even at 1 year of age, we're already picking up the obesity epidemic, not to speak of the women who are absolutely, it's a major epidemic. Now, when we started looking, this graph is similar to the one I showed you before. The 0 line is when the average would be the average. Now using our standards, not the old American standards, okay? If you take countries from a number of low and middle income countries, and here are 54 countries, what you see is that children are born pretty close to the ideal weight. A little bit less, and this is weight and height. But then they falter. They falter until about 2 years of age. And this graph is being reproduced, hundreds of times because it is a justification for the 1,000 days. That window of opportunity for nutritional and other interventions starts at conception and more or less closes at 2 years. We're not saying that there's nothing you can do for a child after the age of 2. Of course there is. But if you have scarce resources, you have to focus on this time period when the children are faltering. They're growing less than they should be. After that, they grow pretty parallel to the standard, but they already accumulated a deficit over the first 2 years. Well, then we started collaborating, our work got better known. The Lancet, the journal, wanted the series on maternal and child undernutrition and invited me to coordinate the paper on the long-term consequences because of our cohorts. I contacted colleagues from the 5 biggest cohorts in low and middle income countries, the 5 longest running cohorts. Just by luck, there's one in each part of the world: Central America, South America, Asia, Africa, and Far East. And we started doing a number of analyses. So we started showing how early growth is important throughout the life course. So if you don't grow well in the first 1,000 days, your risk of chronic diseases is increased as an adult. That's the so-called Barker hypothesis. Many of you are aware of that. It was originated by David Barker in the UK. But the advantage, quote unquote, the advantage we have is that we have a much wider spectrum of undernutrition than Barker had with his UK data. So we took data from these 5 low and middle income countries. And to make a very long story short, I have this graph. My colleagues, I think communicating is really important. So my scientific colleagues say, oh, this is Cesar's cartoon. It's a cartoon. It's not a graph. It doesn't have confidence intervals. It doesn't have, it's a cartoon. But when we take everything we learned from the 5 cohorts and we publish, over 30 papers, the good things, such as surviving, not dying, and accumulating human capital, which includes intelligence, which includes your reproductive ability in the next generation, your adult height, all of these things constitute human capital. The good things, if you put on weight early in life, and from birth to about age 2, you are more likely to survive. You are more likely to be more intelligent and more likely to be a tall adult, or not a tall adult, but reach your biological potential for growth. So the good things are positively associated with weight gain early in life. Well, what about the bad things? Well, the risk of NCD really increases when you gain weight after 2 years of life, not before. Even there's some protective. You see the line there, slightly below 1. 1 would be a no excess risk. For example, low birth weight. If you have low birth weight, you're more likely to have diabetes, for example, or cardiovascular disease. If you put on weight between in gestation or in the first years, you protect against these conditions. And so when you mix the two, you get this. And therefore, I think one real contribution from the work of the cohorts was to say that let's not worry too much in a low or middle income country setting. That's what I'm talking about. Let's not worry too much about kids putting on weight early on. They are building lean mass. They're building their brain, their liver, their kidneys, their pancreas. And after 2 years, basically weight gain results in fat mass, which increases the risk for cardiovascular disease. So I think that was the contribution for this. Rapid weight gain before 2 years of age, 2 to 4 years, increases the risk of NCDs. Rapid weight gain after 2 to 4 years increases the risk of NCD, but not before. Linear growth does not have any detrimental effects as far as we know, and improves human capital. So the double challenge for public health is really complex because you have to promote growth up to 2 years, and after that you have to worry about the opposite. It's a real challenge for public health. I'm happy to get back to that on the discussion if this is the case. Now, having a 30-year birth cohort allows us to do some really interesting analysis. And so we started to look at breastfeeding and human capital. And we published this paper 2 years ago. And basically, I just want to start with a little text on the bottom right. In Pelotas, we don't have, in the 80s, we didn't have a social patterning of breastfeeding. It wasn't that the rich mothers and well-educated mothers were breastfeeding more than the poor. Everybody breastfed about the same, and very little, 2.5 months, remember. And then we did all these analyses adjusting for many controlling factors, including the genetic potential for intelligence of the child. We have genetic scores genomic scores that actually allow us to predict how intelligent a child will be. So we can adjust for the genetics. And then when they looked at duration of breastfeeding, all of these graphs, the longer the breastfeeding, the higher your IQ, the higher your schooling, and the more money you make. And that was really striking. Some people ask me about the little dip on the right in the monthly income thing. You know, if you're breastfed 6 to 11 months, you make 500 reais more a month than if you're not breastfed. And then it goes down. And who are these people? You know, they're really intelligent. They're high IQ, lots of schooling, but they don't make much money. I think they're academics and civil servants, you know. That must be the explanation, you know.
There's a threshold.
Anyway, this paper got a huge media attention. I was watching CNN at home at night. The day it came, and it wasn't CNN rolling. Major Brazilian studies show this. And we also got some not quote unquote negative feedback saying, oh, you're blaming women for not breastfeeding. And then we come back, and one of the main points about the breastfeeding is that it's not the sole responsibility of a woman, it's a societal responsibility. If you have maternity leave that only lasts, a few weeks, as a case of U.S., how can you breastfeed, or how can you breastfeed exclusively? You actually can, but it's really hard. So that paper got a lot of, and it's just an example of how a long-term birth cohort can tell you things that you cannot find out with any other kind of study. Now, the first 1,000 days is being widely acclaimed. It's not, I'm saying we have provided some of the data, and by far not all of the data. Hillary Clinton had a campaign in the U.S. It's also related to development. The first 1,000 days is very essential for intellectual stimulation of the young child. But we were happy that our graphs, our analysis have contributed to this. Okay, so let me move on to the last point. And I want to tell you, as I started working in Brazil and got better known, and our studies started to be quoted and cited, and as Brazil improved a lot, infant mortality in Brazil, when I started, was about 10% of the kids were dying in the first year of life, and now it's 1.3%. So Brazil has made a real change due to many reasons. But I started concentrating more on Africa and Asia. So I started traveling internationally. And in 2003, we had this meeting in the beautiful place in Italy, Bellagio. Some of you will know that. And we said we need to launch a way of a mechanism for accountability for country progress in terms of the health of women and children. And we launched the countdown to 2015. 2015 was the year of the Millennium Development Goals. We had a report every year for that period. It was a multi-stakeholder initiative. CEDA is here, but not IDRC, Jean. We'd be very happy to add your logo, with the proper grant, of course. The beauty of the countdown, I think, is that in 2 pages we summarize everything we know about a country. We do data analysis from data sources, the main points that I am particularly interested in is the analysis of inequalities in health. Because in every country, the poorest the country, even the poorest countries you can go to, there are inequalities within that country. So there's some people who are doing better than others. And when we did the series in The Lancet in 2003, we said we need more of the same is not enough. We can't judge progress on the basis of a national average. We have to find out how the poor, how the ethnic minorities, how the rural inhabitants are doing in each country. And that's when we designed this graph again, a very simple graph. We called it an equiplot. So we came up with it, and we comparing different countries. The gaps, the lines here go from 0 to 100%. So we see what percent of women and children get family planning, antenatal care, delivery care, vaccines, and so on. If you look at, and then we put 2 circles and a line between the 2 circles. And the circle on the right is the top 20% in terms of income of the population, not income but wealth. We have a fancy method for assessing wealth. And then on the left, we have the poorest 20%. And just look at those bars for Nigeria. There are huge gaps. So within Nigeria, the poorest 20% are often coverage around 10% or less. The richest 10%, 20% are over 80% coverage with these life-saving, effective intervention. Malawi, for example, is much more equal. So we don't need to use the same approach in Nigeria and Malawi. So we can go back to the countries and we can work with them. There's a lot of country ownership of this process and reducing these gaps. And we think that the equity analysis that we do are very important. This is the first book that came out of the 1982 cohort. It's called Epidemiologia da Desigualdade, which is epidemiology of inequality, which was the most striking aspect of our cohort up front. We published that. And I always think that inequalities in health are very important for ethic reasons, for human rights reasons, but also for practical reasons. We can have much better programs if we take into account inequalities and if we plan strategies for reducing them. This is what happened to Brazil. Again, I want to show some good things about my country. It's on the bad news all the time in the news here. But this is what happened over the past, since 75 to 2007. Again, this is the same graph, and this is stunting prevalence. This is the other way around. The poor have more than the rich. And look at the huge gap we had between the income quintiles in 75. The poor had 60% stunted. The rich had about 12, and now they're much closer. I mean, look at the improvement in malnutrition among the poor in Brazil. I think a remarkable finding, and we're happy to be part of that process. It depended on many policies, but we helped monitor what was happening there. Now, the new challenge now are the Sustainable Development Goals, which you're all familiar with. There are 17 of them. And we transitioned from Countdown to 2015 to Countdown to 2030. The University of Pelotas has a big role. We do most of the analysis that are included in the reports. We do those locally in our group. We take surveys. We have over 350 surveys now in our database from 110 countries. So we keep analyzing those surveys with a very strong focus on equity. And if you go to the WHO website, there's something called a Health Equity Monitor there, where you can do interactive graphs and charts for inequalities in each country, and all the data in there are provided by Pelotas. So we provide the data behind this whole website, interactive website. Now, I want to go back to the 80s. The two major projects that started us off are IDRC funded, so thank you guys, We haven't had IDRC funding in a while, so this is a good opportunity, perhaps, to rekindle, Yeah, a promise renewed. And I started with this mode of think globally, act locally, and I think what we managed to do in these 35 years was that we actually thought about our local problems and did research to find out more about them, and we managed to act globally and put Pelotas on top of the world. Thank you.
Thank you very much. Please have a seat. So we'll go to the conversation with Cesar. A brilliant talk. But, I won't make an intervention. I'll wait at the end. Shaitali Singha, our senior program staff with the maternal and child health program, will be starting the conversation and will lead us also to the exchange. And that way I can recuperate my camera to make picture and send to a Twitter feed. Cesar, Shaitali, up to you. Thank you.
Thank you. Well, thank you very, very much, Dr. Victora, for a very informative and a very inspirational talk. I think you've demonstrated over and over again through your 4 decades of research the power of research and the changes that it can really result in. And as somebody who works on issues of maternal and child health on a daily basis, I would like to personally thank you for the work that you've done and the resulting positive impacts it has had for millions of women and children around the world. Now, I can sit here and talk to you for, I think, days on end and asking you many questions, but that is not my role here. My role is to moderate questions that are coming from the floor. That being said, I will ask you just one question to get things started. And that is a question. You've showed us many successful examples of changes that have happened in global health policies, in practices, and changing mindsets. Could you give us a little bit of insight based on your experiences and based on your observations? What have been some of the big misses in global health, and what can we do as a research community to avoid repeating these mistakes as we are now in the Sustainable Development Goals era?
Thank you. I think, forgive me for using a military analogy. I think we're investing too much time and energy on magic bullets, and we're forgetting about the guns. It's not a lucky, maybe not a happy analogy, but the guns are the implementation systems, the delivery channels. We have lots, the main problem, I showed you the graphs on Nigeria. We have vaccines that have been around for 34 years, and they're still not reaching those kids who most need them. And scientists are rewarded largely on finding new exciting discoveries, and less rewarded for working on how to implement them. Because the implementation is often context specific. What works in a country may not work in another one. You don't really get universal truths from implementation research. But in the last 20 years or so, I've been more and more involved in global health, in evaluating large programs run by UNICEF, by Canadian CIDA. I've evaluated several Canadian CIDA-sponsored programs, which were funded through UNICEF. What I find is there's a lot of good ideas, there's a lot of good innovations, but people don't pay enough attention to research on how to implement them in an equitable way so that they actually reach the poorest and the minorities and the rural inhabitants who mostly need these interventions. So I think we have this imbalance. It's scientists get brownie points for publishing a paper on a new vaccine or a new drug, and they are not sufficiently rewarded for doing research on how to implement it.
That's great. So we should really be paying attention to the systems that are implementing things. Great.
Absolutely.
Well, I should now open the floor to our audience to ask questions. And nous vous invitons de partager.
So we'd ask you to ask your questions in French or in English.
English or French. I would ask that you come and use one of the microphones. There are 2 here. Please state your name and your organizational affiliation before you state your question. And just in the interest of providing enough time for others to ask their questions, if you could be targeted and brief in your question, that would be very appreciated.
Thank you. My name is Colleen Duggan, and I work in the policy and evaluation team here in IDRC. I was quite struck in your inequities and inequalities research on the graphic showing Nigeria and Malawi. And I guess giving a call out for transdisciplinarity, I started to wonder about what are the other social determinants behind inequities. Yes. And so I was wondering if your group has, do you adopt a transdiscipline approach, and have you been able to move farther with that research to look at some of the social contextual inequities and other social determinants which lead to inequities, and therefore, which for me is sort of very directly tied to this issue of implementation systems.
Yes.
And we will be taking one question at a time.
Yeah, I prefer to do one by one.
Absolutely.
Is that okay?
Yes.
No, thank you. Very good question. Obviously, the inequities are... I think the number one question someone from the health sector like I am has to ask is, am I part of the problem or am I part of the solution? Because what I find is that in many countries, the health sector is part of the problem. So inequities have all these huge social determinants, which are really macro-level determinants. But we in the health sector, we compound the inequities by not planning services that are pro-poor, putting the health centers in the wrong places, or cultural barriers to access services in many communities in Latin America. This is a real issue. The indigenous communities are way behind because of cultural barriers in the use of Western style services. And then we also put in income or economic barriers. I mean, many countries adopted user fees in the 80s and 90s at recommendation from the World Bank and IMF and so on, and that has a disastrous effect on healthcare utilization. There also, it's not only the direct out-of-pocket payments for healthcare, and where we see the biggest gaps actually is delivery care, maternity, childbirth care. Because there's a distance, there's a transportation cost, and then they have to pay to deliver in the hospital. And this is where you see Nigeria, 10% of the poorest quintile delivered in a hospital compared to 90% of the richest. Now, having said that, after we do our own mea culpa and we look at our own, how are we helping, we also have to think about what works in terms of reducing inequalities. I have two good examples that I've studied quite a lot, which are Brazil and Peru. Both Brazil and Peru, for a number of successive governments, have put priority on eliminating poverty. And Peru was fantastic. The major goal for development in Peru from 2000 onwards was reducing stunting. They say stunting is the best indicator for poverty. Child stunting results from three things: poor nutrition, infections, and poor care, loving care, care when you feed your child, when you look after your child. Now, so therefore, stunting is a very good overall measure of quality of life in any country. It's even better than child mortality. Infant mortality is easier to reduce with magic bullets, vaccines and antibiotics and so on. But stunting is really hard to reduce unless you have a trans-sectoral policy. So how did Brazil and Peru manage to reduce stunting so much? And I showed you the graph for Brazil. Peru is very similar. It was to put equity first in policies in all sectors: education, communication, transportation, electricity, and also the very strong conditional cash transfer programs. I'm not going to discuss whether conditionalities are important or not, but the cash transfer programs in Brazil and Peru led to a huge reduction in inequalities. We had progressive governments in Brazil who took 40 million people out of poverty. That's like Canada, it's one Canada. And they came up out of poverty. That was really a massive investment. So you have to tackle inequalities within the health sector, but also through intersectoral action.
Good morning. My name is Mark Farron. I'm a consultant on international health.
I was talking about you today.
In the interest of transparency, I must confess that I've known Cesar, and all I can say is parabéns y obrigado.
Muito obrigado.
Thank you so much, and congratulations on all these many years of the trajectory of building more momentum and engaging a global conversation based on a local experience, and as we all know, a small scale, sort of nondescript unassuming town called Pelotas, that you could, make it on top of the world. I'd say my hat off to you.
Thank you.
Cesar, I wanted to engage you a bit on the question of now that we've made a lot of progress in Brazil, and I've been associated with Brazil about 40 years myself through my family and visits, and we're all, very impressed and encouraged by reducing poverty in a very serious way, in the material dimensions of poverty, the epidemiological dimensions of poverty. But I'm sure you read a front page New York Times article last summer, I think it was, about the boom in obesity in Brazil. Yeah. And I read that article in some detail, and many things were important, multinational corporations and a lot of things, prosperity, the fact that people before who never eat meat or once a month, now they're eating maybe every day or too much, and sugary drinks and all this. But it seemed to me a big cultural blind spot in that New York Times review, and it was the disappearance of the empregada, of the maid. It used to be in Brazil, the maid of the middle and upper middle class would go out every day and buy real food, real vegetables and ingredients, spend all morning preparing, and at noon, and maybe at noon and in the evening, there was a freshly cooked, nutritious, balanced meal every single day. Yes. Prosperity has eliminated the maids. And that middle class and upper middle class, they never learned how to cook. So here we have a very new challenge, cultural challenge. Yes. It's not the bullet. Yes. It's not the gun. I think it's a whole new conversation of the dangers of prosperity. And how do you prepare and immunize and anticipate now that we're working on a global scale? Let's not repeat the errors of Brazil. Thank you so much, Cesar.
Thank you very much.
Pleasure.
Well, I was mentioning your name this morning, Mark, and reminded when you and Carl Smith and Jane McDonald came to Pelotas to support our work, and then you supported the Latin American network on perinatal health, and fantastic work, you guys. You guys really helped us. Thank you very much.
One more thing I forgot to mention. Indeed, I think I recall visiting.
Would you mind going to the microphone? Thank you.
But it's a more personal anecdote and related to Cesar. You were always too understated and too humble. But I recall that you did have an encounter with cancer in the late 80s.
Yes.
And I admired so much, your resilience and your motto was, work was the best therapy. And I remember dropping off some of that, antiquated CDs or, probably floppy disks so you could use the microwave.
Yes.
So I was part of another journey, but a very touching and important memory. And again, another reason to say, bravo, work indeed is the best therapy. Thank you.
Thank you very much. Thank you. I just... I think, Mark is an example of what the good things that IDRC did. And the fact that you guys came down to see us, we have had many grants from many agencies, but we were never so closely watched. Big brother. No, it was great. I just wanted to come back to the obesity epidemic in Brazil. And that's for sure, we used to cook our meals, or either us or a servant, the domestic servant. My family was upper middle class, so we always had servants who cooked rice and beans. And now it's all frozen food and fast food, and we're having a real issue in Brazil now, a real problem. We had governments that were more interested in poverty and eliminating poverty, and the industry was not so strong. We managed to regulate the industry, not as much as we wanted. But now the lobby of the big food industry is all over the place. We're trying to do like Mexico did, tax cola drinks. We can't. It doesn't get through Congress. And Mexico's got a great experience. They're reducing overnutrition. Now, Mark, one very perverse aspect of equity. Equity is always, you always think, equity is good. No. What's happening in our cohorts is that there's no inequality now in overweight because the poor are just as fat as the rich. And it's starting to reverse. Now it's the rich, what's happening in the high-income countries where the poverty is associated with overweight and obesity, and that's just starting to happen in Brazil. But for many times, the poor didn't have enough to eat, so they didn't have obesity, which was good, right? But they had stunting and they had undernutrition, underweight. Now there's no more difference. They're all at the same level. So, and I think it's really the sort of issue that you cannot tackle within only the health sector. Again, back to your question, part of the social determinant is the role of industries in promoting, cheap, high-calorie, high-fat foods, and the inability of the government to control them because of economic interests. So it's a real challenge. There's a lot of discussion in Brazil now about this, and I just hope we can follow Mexico and other countries which are taxing junk food.
Wow, that was a nice blast from the past. We were talking about your name today, and that was fantastic that you were able to come. Thank you so much. Are there any other questions that people would like to share?
Hi, bonjour. Mon nom c'est Aïcha Koné de l'Université. Aïcha d'Ottawa. I work in international development. My name is Aïcha. I work in international development. Thank you for your presentation. I know that breastfeeding helps preventing many problems, but and namely child mortality and social inequities. But my question is, I'd like to know if there are studies that give us a vision of is there an emergence in Africa, for instance, of breastfeeding? I'd like to know if women are more and more interested in feeding their children, breastfeeding, or if they're not really interested in doing this. And I was wondering what kind of policies we should have to promote that.
Very good question. About exactly 2 years ago, we did a large overview of breastfeeding in the world. We got data from 150 countries, and we published 2 papers, a series of 2 papers. The first one was the epidemiology of breastfeeding, inequalities in breastfeeding, and the biological advantages for mother and child. And the second was policies, support, barriers. So this series, in a nutshell, I'm going to tell you what the main findings are because I think these are important. They are the answer to your question. Number one is breastfeeding. It was for a long time was seen as being important for child survival, morbidity, diarrhea morbidity, pneumonia morbidity, other infectious diseases in childhood, and for child nutrition. So that was the idea. That's what breastfeeding is good for. We're trying to change that. It is really good for these things. But it also has long-term consequences for women and children. Number one, not many people are aware of the very strong evidence from over 100 studies on breastfeeding and breast cancer. Breastfeeding reduces the chance of breast cancer. Every 6 months that a woman breastfeeds reduces breast cancer by 6%. So if a woman has 2 children and breastfed both for 1 year each, so she spent 2 years breastfeeding, her chances would be reduced by 6%, 6%, 6%, 6%. It's a pretty important reduction. Reduces ovarian cancer. There's some evidence that it reduces the risk of diabetes and cardiovascular disease in women too. So it's important for the woman. It's also important for long-term human capital. That lots of studies show similar results to ours. Ours was the first one to show an impact on income, but on intelligence, the evidence on intelligence in breastfeeding is pretty strong from many different studies. So we're trying to change the idea that breastfeeding would only be important, say, in rural Africa. No, it's important throughout the world. Now, back to your specific question. What we find is, in terms of equity, we find that in rich countries, educated, high socioeconomic position women are more likely to breastfeed than the poor. This is the case in Canada, it's the case in US, in England, in Sweden, you name it, okay? In poor countries, it's the reverse. This is because breastfeeding is a cultural practice, and formula hasn't really been introduced that strongly because it's costly. It costs money. We're now in the middle of a large project with WHO. We're getting formula sales data from all over the country and formula promotion, strength of formula promotion by country, and relating that to trends in breastfeeding. Now, having said that, the really important thing in Africa and in poor countries in Asia or Latin America is how can we prevent the poor from giving up breastfeeding, because their rates are pretty good. At 1 year of age in Africa, typically 80 or 90% of the infants are still breastfed. So number one, how to protect breastfeeding from commercial pressures. Number two, how to promote exclusive breastfeeding, because what you find in Nigeria, for example, or in Malawi or in Angola, is that women breastfeed for a long time, but they start using those little bottles with teas and water and juices and thin gruels very early. So we have about 45% of the world's population, if we count all the children in the world, are exclusive breastfed. The more 55 are not. And in some African countries, it's even lower than that. So it's a dual challenge, right? How to promote exclusive breastfeeding for everyone, and how to stop the poor from abandoning breastfeeding and adopting formula. Well, many of you know there's an international code for the commercialization of breast milk substitutes, and this international code is adopted by some countries but not by others. I think that's the first measure. The code means that you cannot advertise formula as being healthy. You cannot put baby pictures on formula. You cannot distribute free samples of formula in hospitals. There's a whole bunch of measures that are included there, and unfortunately, some countries still do not adopt the code. Brazil, I want to go back to Brazil and say a couple of good things about my country again. I mean, there's lots of bad things, but again, we had 2.5 months of average duration of breastfeeding in 75, and it's now 14.4 months. So the average Brazilian woman breastfeeds her baby for more than a year. So it's the greatest success story from any country that I know. And we've reviewed the literature for over 150 countries. And that was done through a multi-sectoral approach, baby-friendly hospitals, strong enforcement of the code by civil society as well. IBFAN is very strong in Brazil. IBFAN is an NGO that basically monitors the adoption of the code. We had the largest network of human milk banks in the world. We have over 200 human milk banks. We have very strong promotion of breastfeeding. And it shows that you can revert the decline in breastfeeding, which went to a low of 2.5 months in the 70s, you can revert that and you get to over a year.
Thank you so much, Dr. Victora. I'm Manpreet, and I am the Senior Technical Advisor for Food Fortification with Nutrition International. Yes. And before joining headquarter NI here, I was the Asia Project Manager for Technical Assistance for Nutrition, and I was working with 7 countries that have joined the Scaling Up Nutrition movement. So the point is that and you've been saying this multi-sectoral approach is very important, and we cannot ignore the role of the private sector. I have seen country governments struggling with having a successful Sun business network and the partners joining the network and sustaining the momentum. And I have also personally felt a rift between the civil society network and the business network, and discussions about the conflict of interest and those documents and, how to implement those and all of that stuff. So my question to you is, what is your suggestion for these governments? How can breastfeeding be promoted and interventions like breastfeeding be promoted when there is such a strong presence of business communities with their vested interests? How can they be brought on the table and, discussed at length so that it's a win-win situation for both? Because it is easier said than done. There's a very thin line, and we know the business community is there to make profits. So what is that message for the governments? How can they actually promote this business network and still have them discuss all of these measures? Thank you.
Thank you.
Just the
I wish I knew the answer. I wish I knew the answer. Yeah, I think what you do need is you need to get civil society and the population involved. And frankly, I think you need to control. I think the best way to interact with industry is regulation. You really have to regulate and monitor. I'm not a great fan of promoting, public-private partnerships as a solution to a number of things. I mean, they could work for something like vaccine development, maybe, but for many things, we really need a government to stand firm and say we're regulating. No infant formula advertising. No distribution of free samples, taxation on junk food, and so on. And so I'm not sure I have the answer, but I think the countries that manage to improve breastfeeding, like Brazil, regulation, control of advertising, free samples is a strong thing. We still have some way to go. I think we still allow formula industry to sponsor, pediatric meetings and to provide gifts to doctors. Those are still allowed. Some countries are taking measures against this kind of incentive. But I think strong regulation and monitoring is, and industry can make money in other ways. I mean, they don't have to make all their money by selling formula. They can sell other types of products. And so that's my view, but I'm I have a tough stand. I never took any financing from industry, which is hard when you're doing research in pediatrics. I mean, they come to us, all the time. They come to us, and we have to stand firm and say no. IDRC, yes. Industry, no.
Thank you very much for this fantastic presentation. Just on the subject of financing, I was at a meeting earlier this week where most researchers were complaining that they don't get enough funding to do long-term longitudinal studies for cohorts. So just for your advice for other researchers who want to do similar projects on and follow populations for a long period of time, what is your secret?
Oh, good. We were recording a video just before this section with John, and he said, "What do you advise to young scientists?" And one of my advice is, don't give up. There's something called, as you know, there's something called donor fatigue, right? A donor will fund a certain project for 3, 4, 5 years, and then they'll say, "Oh, we're having other priorities, and we're changing, so we're moving on." So you have to find another donor. So let me just tell you who has supported our cohorts. IDRC initially, kickoff. Overseas Development Association, ODA, now DFID in the UK. UNICEF. Wellcome Trust. The Wellcome Trust were very generous. They funded us for 10 years. And now the Brazilian government took over around 2000. The Brazilian government started supporting our cohorts. So, and I'm sure I'm forgetting one or two funders, but they're every few years we had to apply again. And the problem with cohorts is that it's not like doing a trial or something that if you don't start today, you can do it in a year or in 2 years. A cohort, you know, they will only be 4 years old in 1986, you know, if you don't get funding for that year. And then some people, let me just tell you another question. Some people ask, why do you have a cohort in Pelotas every 11 years? We said, no, we actually wanted a cohort every 10 years, but the 93 cohort funding was late. We eventually got funding from the 93 cohort from the European community, but it was late. They only arrived after we wanted to start. So it is a difficult thing. I know there's a big initiative now by Wellcome Trust for funding cohorts long term. They're just starting this initiative, but it is hard, and you have to apply to several donors to make sure that at least you get to fund from some of them.
Well, I think with that, I think we're going to close the question and answer period. And I'm just going to summarize, which I heard the 3 words come through. I think the vision for seeing a problem and following through, persistence, as you said, never give up, and creativity. I mean, finding ways to make things work. So thank you so much. And I'm going to hand it back over to Jean.
Thank you very much, Idali. Thank you very much, Cesar. And thanks to all of you. Wasn't it a great presentation? Tell your friends or family that are not aware what is IDRC to look at the video, and you see that IDRC is not only us, it's really you and your colleague. And I cannot say how pleased I am to see Mark and to have learned that Mark was part of the story, a common visitor, a frequent visitor to IDRC Talk. And for you probably to meet each other again is fantastic. But it's also a source of inspiration for our staff. And for us, I started 21 years ago in the trenches doing essentially what I had learned to do from people that were there before and what much younger people like Chantalie are doing in order to pursue this journey of excellence. Let me thank also Summer Whitlock for, on behalf of IDRC, to the Gairdner Foundation. I think that John Dirks, who has been at the head of the foundation for many years and has left his name to the Canada Gairdner Global Health Award, needs to be commended for his vision of bringing global health at the forefront. Now, those of you that are not necessarily very familiar with Gairdner, there's an untold story is that if you get a Gairdner Award, sometimes you're very well placed to get a Nobel Award. And over the year, you know, I've seen it with Dr. Umura, who was the inventor of ivermectin, an antibiotic that, you know, reduce or cure river blindness. He visited us in 2014. He got the Nobel Prize in 2015. My colleague, Peter Piot, at the London School of Hygiene and Tropical Medicine, you know, co-discovered the Ebola virus in the 80s. His first international grant was from IDRC, same magnitude that the one that Cesar got. And still today, you know, he's making a reference to, I was with him Sunday night, and he says, please extend my greeting to Cesar, because Cesar is also a fellow at the London School of Hygiene and Tropical Medicine. So, breastfeeding, Cesar. From a very simple journey back in the 80s, you did it all. We only provide a bit of support, but you did it all. But we tend to forget something also extremely important to me, is that we owe a lot to the population of Pelotas and to the member of that cohort. And I think these people should be celebrated at one point, because they are the one that have made the science possible. And often it goes unnoticed that in public health and in many other fields, particularly when we talk of research for development, all of these great findings and these solutions happen because they have been participant. They have people that have given their time, that have given sometimes sample, that have spent time in clinic, have answered questionnaire, and, have given really to the world, the knowledge that we needed in order to have the type of solution that has been done. Having done my PhD largely in Brazil, in the north, you in the south, meeting here in Ottawa is a keen reminder also for me, Cesar, that as you go back to Pelotas, and if you are still interacting with these cohorts, could you extend, on behalf of all of us at IDRC, our sincere thanks? And I will get a step further in telling you that it's been too long that I've been in Brazil. And I'm committing here publicly that I will get to Pelotas and pay a visit, because this needs to be, I think, celebrated, and those people needs to be thanked, as well as all of your team at the university. So, with this said, I have a token of appreciation for you, Cesar. IDRC is good at finding people, but IDRC is good also at keeping what people have been doing. So, thanks to our library services that are doing fantastic work, I was able this morning, to dig in the database myself and to print out the report that you have produced, in 1985, that is called The Design and Conduct of Case Control Studies to Investigate the Relationship Between Infant Feeding Practices and the Risk of Infant Death. That is to have been published in July 1985. Now, I was a little bit puzzled because the report is really, the article that you, Peter Smith, have put together.
Yes.
But when I look deeper into it, in the appendix, there's the technical report dated May 1985 of the work that IDRC has sponsored, and you did produce the report, and we kept the report. Wow. And it's even mentioned that we have financed you. So, you did it all right. And the beauty of it is, I think, that you were already aware that you were sitting on a gold mine with the population of Pelotas, because there's a very nice mention over here, do not cite or quote, because it was getting published, and there are peer review publication rules. Yes. So it's a great honor for me. So thank you for this fantastic talk, for having been such a researcher that is an inspiration still today, and as a token of appreciation, please accept the report.
Thank you very much. Thank you. Well, thank you. You have wonderful archives here.
Yes. That's sometimes a problem.
Yes.
Thank you very much, everyone. Thank you, everyone.
Thank you very much.
YouTube
Thank
channel,
you.
And see you next.